Moving on, our next presenter is Dr. Erica Mayer of the Dana-Farber Cancer Institute in Boston, who will present GS306, palbociclib after CDK4/6 inhibition and endocrine therapy, PACE, a randomized phase 2 study of fulvestrant, palbociclib, and avelumab for endocrine pre-treated, ER-positive, HER2-negative metastatic breast cancer.
Thank you so much. Good morning, everyone. On behalf of my co-investigators, I'd like to thank the committee for inviting us to present results from the PACE trial, a randomized phase 2 study of fulvestrant with or without palbociclib after progression on CDK4/6 inhibitor for hormone receptor positive, HER2-negative metastatic breast cancer. These are my disclosures. The combination of a CDK4/6 inhibitor with endocrine therapy is a standard of care for metastatic and high-risk early hormone receptor positive, HER2-negative breast cancer. Mechanisms for resistance to CDK4/6 inhibition are under study, and it's not clear if alterations at the time of disease progression provide resistance to CDK4/6 inhibitor, endocrine therapy, or both. Thus, whether a CDK4/6 inhibitor should be continued at time of disease progression has been an open question. Preclinical data suggest combination therapy with a CDK4/6 inhibitor and checkpoint inhibition beyond prior progression may provide synergistic efficacy. Therefore, the PACE trial was designed to explore the activity of continuation of CDK4/6 inhibitor beyond progression with a change in endocrine therapy to fulvestrant, and to explore the addition of PD-L1 inhibition. Eligible patients had hormone receptor positive, HER2-negative metastatic breast cancer with progression on a prior CDK4/6 inhibitor and endocrine therapy containing regimen, with at least 6 months of disease stability on that regimen or exposure in the adjuvant setting. Patients could have up to 2 prior lines of endocrine therapy for metastatic disease, no prior fulvestrant, and up to 1 prior line of chemotherapy. Patients are randomized 1:2:1 and stratified by whether they had exposure to chemotherapy between the prior CDK4/6 inhibitor and entry onto trial. Patients are randomized into one of 3 arms: fulvestrant alone, fulvestrant and palbociclib, fulvestrant, palbociclib, and the PD-L1 inhibitor avelumab. Palbociclib dosing started at 125 milligrams unless the patient entered the trial having received a lower dose, in which case they could start at that lower dose. Correlative samples were collected at baseline and serially while on study. The primary objective of the study was to compare RECIST-confirmed progression-free survival for the fulvestrant and palbociclib arm versus fulvestrant alone. Secondary objectives included to compare PFS for the triplet of fulvestrant, palbociclib, and avelumab versus fulvestrant alone, response endpoints, safety, and outcomes in predefined molecular subgroups. Total planned enrollment was 220 patients. For the primary objective, comparing fulvestrant and palbociclib versus fulvestrant alone, 119 RECIST-confirmed PFS events would be required to detect an improvement in median progression-free survival from 4 to 6.5 months. For the secondary objective, comparing fulvestrant, palbociclib, avelumab versus fulvestrant alone, 63 PFS events would be required to detect an improvement from 4 to 7.5 months. 90% confidence intervals are reported due to using one-sided alpha. A DSMB reviewed the trial every 6 months for safety and 1 protocol-defined interim analysis for futility. The DSMB endorsed a decision to lock trial data in July 2022 after all enrolled patients had completed at least 1 restaging scan. 113 of 119 PFS events are reported for the primary objective. Between September 2017 and February 2022, 220 patients were enrolled from 13 U.S.-based cancer centers, with 216 initiating treatment. At time of data lock in July 2022, the median follow-up is 23.6 months, and 18 patients continue on protocol therapy. Regarding patient demographics, the median age of the PACE population is 57 years. In general, the three arms are relatively well balanced. However, I will point out that the fulvestrant alone arm had somewhat more favorable clinical characteristics, with numerically more patients being postmenopausal with de novo metastatic breast cancer and fewer patients with visceral disease. Regarding prior treatment, 3/4 of patients were defined as endocrine sensitive, and 3/4 had been on their prior CDK4/6 inhibitor regimen for over a year, which for the majority of patients was a palbociclib-containing regimen. Also, 3/4 of patients entered the trial to receive second-line therapy for metastatic disease, and only 16% had had prior exposure to chemotherapy for metastatic breast cancer. For the primary endpoint of progression-free survival, continuation of a CDK4/6 inhibitor using palbociclib with a change to fulvestrant did not improve progression-free survival versus changing to fulvestrant alone. The median progression-free survival for fulvestrant and palbociclib was 4.6 months, and for fulvestrant alone was 4.8 months. A sensitivity analysis was performed using both RECIST-confirmed and non-RECIST-confirmed PFS events and supported the primary analysis. The median progression-free survival in the triplet arm of fulvestrant, palbociclib, and avelumab was nearly doubled at 8.1 months. 12-month progression-free survival was 17.5% for fulvestrant alone, 13.1% for fulvestrant and palbociclib, and nearly triple at 35.6 months, or 35.6% for fulvestrant, palbociclib, and avelumab. This forest plot shows subgroup analysis. For the very small number of patients who had an intervening systemic therapy between their prior CDK4/6 inhibitor and entry onto trial, there was a trend towards benefit from continuation of CDK4/6 inhibition. Additionally, for patients who were defined as endocrine resistant, there was also a trend towards benefit from CDK4/6 continuation. The overall response rate in the measurable disease population was 10.8% for fulvestrant alone, 13.7% for fulvestrant and palbociclib, and 17.9% for fulvestrant, palbociclib, and avelumab. The clinical benefit rate followed a similar trend. At the time of data report, 83 patients in this trial have died of their disease. Overall survival was not a pre-specified endpoint. However, given the duration of follow-up, overall survival is being reported. The median overall survival for fulvestrant alone was 27.5 months, for fulvestrant and palbociclib, 24.6 months, and for fulvestrant, palbociclib, and avelumab, 42.5 months, a pattern similar to that which we just saw for progression-free survival. About 50 to 60% of patients initiated palbociclib at a starting dose of 125 milligrams. The rest started with a lower dose consistent with what they had previously been receiving. Palbociclib dose holds and dose reductions are as listed on this slide. Notably, no patients were reported to have stopped all protocol therapy specifically due to unacceptable treatment-related toxicity. Here are the adverse events in the PACE trial. Rates of hematologic toxicity in the palbociclib-containing arms are consistent with what we would expect from palbociclib, or as expected. Mild to moderate fatigue, nausea, and diarrhea were the most common non-hematologic toxicities which were observed. There were no episodes of febrile neutropenia. There were no grade 5 toxicity events. Rates of immune-related toxicity in the triplet arm containing avelumab were low, as shown in this table, and there were no unexpected IO-related toxicities. A ctDNA sample was obtained at baseline and evaluated using the Guardant 360 platform. 200 of 220 patients had a baseline sample available for ctDNA analysis. 3 pre-specified mutations were evaluated: ESR1, PIK3CA, and RB. Rates of baseline mutation status included 54% for ESR1, 35% for PIK3CA, and about 12% for RB. Exploratory analysis of baseline mutation status and clinical outcome is shown here. Patients who had a baseline mutation in one of the 3 specified genes trended towards more benefit from continuation of CDK4/6 inhibitor, the presence of the mutations perhaps indicating endocrine resistance. Let's look at this a little more closely for ESR1 mutations. If I can ask you to focus on the blue line, which is the fulvestrant alone population. On the left is the graph for ESR wild type. You can see that outcomes in fulvestrant alone patients are favorable compared to the other groups, the other arms. In contrast, for the ESR1 altered population, outcomes in the fulvestrant alone arm are less favorable and appear to be improved through the addition of the targeted agents. A similar pattern was seen in patients who had PIK3CA wild type versus PIK3CA altered tumors. Therefore, in conclusion, in this randomized phase 2 study in patients with hormone receptor positive HER2 negative metastatic breast cancer, combining palbociclib with fulvestrant beyond progression on prior CDK4/6 inhibitor did not significantly improve progression-free survival compared with using fulvestrant alone. The observed longer progression-free survival when a PD-L1 inhibitor was added to fulvestrant and palbociclib is an intriguing signal in this hormone receptor positive population and deserves further study. No new toxicity signals were seen, including no unexpected immune-related toxicity events. Baseline ctDNA analysis suggests possibly differential impact of targeted agents based on the baseline mutational status. Ongoing evaluation of serial ctDNA and CTC samples from this study will allow exploration of the mutational and resistance landscape, as well as markers of sensitivity to IO therapy in hormone receptor positive disease, and overall a better understanding of the mechanisms driving progression post-CDK4/6 inhibitor and endocrine therapy will help guide more rational treatment selection for subsequent lines of therapy and improve outcomes for our patients. We would very much like to thank the patients and caregivers who volunteered to participate in the PACE trial, the research staff and providers at the 13 participating cancer centers, and the funding support from Pfizer. Thank you.
Thank you, Dr. Mayer, for your presentation. We'd now love to take questions. Microphone number 3.
Matthew Getz, Mayo Clinic. Erica, this is a fabulous presentation. I had a question about the benefit of the checkpoint inhibitor. Was there any sense that the benefit was greater or less based on the duration of CDK4/6 inhibitor that was given in the first line?
Thank you very much for that question. We were really excited to see the results in that third arm of the study, our triplet arm. We don't have the ability right now, based on the small numbers, to correlate prior exposure to CDK4/6 inhibitor and duration of benefit. But I do think a really interesting observation in that arm is that there's such a wealth of preclinical data that suggests the synergy between CDK4/6 inhibitors and IO therapy, which supported this trial. Other experiences attempting to combine a CDK4/6 inhibitor and a PD-1 inhibitor, for example, combining palbociclib and nivolumab, or abemaciclib and palbociclib pembrolizumab have been troubled by toxicities, rising LFTs, ILD. We didn't see that in this study. This was actually quite well tolerated. And whether that's the difference between PD-1 inhibitor and PD-L1, we're not sure. But we think it's a really interesting signal, and we're looking forward to studying this more.
Excellent. Microphone 4.
Thank you very much, Dr. Barilla from Slovakia. I wonder if you have any data concerning PD-L1 positivity in these patients.
That's a great question, and as I mentioned before, we're excited to study this more. We have a lot of samples available, and we'll be looking for all sorts of markers for sensitivity and resistance to IO therapy.
Excellent. We have time for one more quick question. Microphone 3.
Hope Rugo at UCSF. Excellent presentation, Erica, and congratulations on this study. You know, one of the big questions that's come up that Fabrice Andre discussed as well is the control arm for the new endocrine agents, the oral SERDs, the PROTAC. is fulvestrant alone, and that's been because there's very short PFS in general. But your study, patients had a great PFS on fulvestrant alone. What's the secret?
Well, thank you, Hope. I would point out this is a randomized phase 2 study. It is subject to all the risks and benefits of phase 2 design. As I pointed out, although we tried with randomization to have balanced arms, there were some numerical differences in the fulvestrant alone arm, which perhaps indicate a more sensitive population with more favorable clinical characteristics. Perhaps that is a reason why that arm seems to have performed with better outcomes than we've seen in some of the other similar post-CDK studies. I think it's a good lesson to us that we should always be looking at how the arms are balanced and think about how any imbalance could be driving the observations that we see.
Excellent.
Okay, and just one more question. Thank you. Dr. Mayer, so few of the patients randomized to fulvestrant and palbociclib on your study had to switch CDK4/6 inhibitors, whereas on the MAINTAIN trial, most of them did. Do you think that this impacted your results?
Well, thanks, Bill, for that question. And, to put this in context with the MAINTAIN study, which was a study where the switch was to ribociclib, first I point out both MAINTAIN and PACE are randomized phase 2 studies. So again, we have the limitations of that. We also have perhaps the skew from the fulvestrant alone arm that Hope just pointed out to us. And that might be a slightly different population that was in the control arm of the MAINTAIN study. But it does raise the question of what is the role of CDK after CDK, and is it important to switch from one agent to another, as was done in MAINTAIN, where most patients were on palbociclib and switched to ribociclib, or the continuation of the same agent in the PACE trial, palbociclib to palbociclib. I think we can say from the results I've just shown that there's no role to continue palbociclib beyond prior progression on palbociclib. But we do have pending data on this question. There's the Palmyra study also looking at palbociclib, and the post-MONARCH study, which is a phase 3 study looking at a switch to abemaciclib versus placebo. So I hope that data will help us better understand how we can move from CDK to CDK.
Excellent. Thank you.